Good evening, all. Welcome to the second session of Vaidyothami's training programs for young aspiring Ayurveda doctors who are coming into this wide ocean of Ayurveda and its practical parts. Hope we will be able to deliver some amount of confidence in managing orthopedic conditions, which I learned it from my gurus way back in my college education times, in UG times in Trivandrum Government College. Now I remember all those gurus right now, and because of their blessings only, I was able to learn these things. And I want everyone to practice this one in their day-to-day clinical practices. So let's start the session. Today's session, we will be handling about shoulder. We can't, in entirety, we can't take the shoulder aspects, but we will be dealing with a few things which in initial years of practice you can handle. Now, what I meant to avoid right now was about dislocations, which we will deal it later, and certain fractures of the shoulder and clavicle, where the same bandaging technique which we use right now in a modified form can be used. But right now you have to learn the bare level one of bandaging of shoulder. Once you are well versed with this one, we can go into this advanced module that we will conduct later. Right now, we will be dealing with multiple injuries of the shoulder, including rotator cuff injuries, impingement injuries, OA that happens, and frozen shoulder. These four conditions which we commonly get also regularly in our OPD clinics. We get patients who come, elderly patients coming with a frozen shoulder, or sports individuals coming with rotator cuff injuries, impingement problems, or elderly people with who have other shoulder related anomalies, which many a times we will miss to diagnose in a proper way. Actually, all these conditions which I described right now can easily be clinically diagnosed. If you are a good diagnostician, you can easily diagnose it in clinical settings itself by using very few simple tests that I will be demonstrating in this one, and also as a hands-on training later on. Now, the thing with this anatomical part and all that, I'm not going to discuss too much, but we'll be running through the topics but it requires now a brief introduction to the anatomy of these things and what things you need to watch out while you are doing the examination part. Now, at the end, we will go to Varmam. Varmam is actually the Tamil or Siddha version of our Marma techniques. Now, they have developed it in a very beautiful way, and way back in 2011, when I attended the course, it was like an eye-opener for me. Tirumular Varmology Institute was the course conducting person. They were the program coordinators. And it was an eye-opening session for me to think of Marma in a very different way. Today, I will explain to you the Varmam part, but it is not as similar as our Marmam. But slight changes are there, but still we can correlate a lot of things together. And how it is effective in managing conditions, and how, according to the modern anatomy, how it is interlinked also. That's a beauty of the science. Now, way back 2000 or maybe 3000 years, the acharyas who have written this thing, they knew about the anatomy in a proper way. That's what I understood once I studied Varma in detail, or Marma in detail. Now, that is which we can help in lot of injuries of the shoulder in all parts of the body, but in especially in the shoulder area. That also will be explained at the end. And hands-on training will be done on Sunday morning when we meet for the session. Okay, let's start. Now, shoulder joint, as you know, shoulder joint is a very shallow joint when you consider it. It's a diarthrodial joint. The main thing is, there is a very shallow glenoid cavity, and to the glenoid cavity, we have the humerus head coming up. Now, other joints, there are strong ligaments that actually connect and help hold the joint together. But here, that is not that evident. Yes, ligaments are there, But the thing is, the muscles or the rotator cuff muscles with the deltoid and the coracobrachialis, other muscles that comes in that area, those muscles are actually holding. The cuff name itself came with that because it's cuffed into this one, into the axial skeleton. Now, another thing you need to remember with the anatomy part is the entire upper limb. The sole connection to the axial skeleton is at the sternoclavicular joint. That is the only area where the entire thing is connected, the upper limb. Otherwise, the upper limb is a very free thing, and only connection to the axial skeleton is sternoclavicular joint. Now, as the clavicle comes up, it comes laterally, and then we have it comes with the acromion of the scapula and forms the acromioclavicular joint. Now, acromioclavicular joint, that joint is another one where the scapula alone is connected. Scapula and clavicle connected. Below the acromion, we have the shallow glenoid, and it has a labra, like a washer-like thing. Maybe you can imagine like that, so that the head remains inside that washer part. Now, in front, we have the coracoid process. The coracoid process also acts as stabilizing point for multiple ligament attachments in that area that stabilizes the joint. And it's a very confined space. Remember, the main thing, the main injuries that happen because all the tendons are passing through a very confined space, and that is like a tipping point for any injury happening anytime with an awkward movement, whether it is while sleeping, falling down, or playing a sport. Anytime you can get an injury, a trivial injury also is enough. And once the inflammation sets in, there is a vicious cycle that starts to happen. Why? Because inflammation, again, the space is reduced with inflammatory mediators, markers over there. Again, the space is going to reduce. And it's a vicious cycle that go on rotating if you don't treat it in a proper way. Okay, let's start. And today for helping me out or displaying the things, I have Dr. Aravind with me. He'll be joining along with me now. I am calling him to take the seat and I'll be explaining things. Is this visible? Okay, we'll start. Shoulder joint anatomy I have explained. Can you turn this side? Hope everyone can view. Is visible? Yes. Okay. Now we see shoulder joint. Hope it is visible. Ashwin, is it okay? Yeah.
Yes, sir.
Yeah. Okay. Now, few things you need to remember. Shoulder is a very freely mobile joint. Keep it loose. Keep it loose. You can move it any direction or any way you want. Now, this movement actually helps us to do our day-to-day activities, but the main problem is this movement comes up with a lot of compromise also. One compromising position I will show you once the shoulder is abducted plus elbow flexed, and then you do an external. You can see Aravind twitching. Now, the thing is, this is apprehension because this is a very weak point for shoulder. Easily, you can pop the shoulder out. If I want to make an anterior dislocation, it can easily be done in this position. And this is a test also, which usually we do for shoulder dislocation patients. It is called as apprehension test that we will learn later, but just the movement part. Initially, we will start with all the range of movements that shoulder can have. We will start. Before that, I want to tell, we told about the sternoclavicular joint, which comes near our jugular notch area, just to the side. You can see that this joint, it helps in about 30 to 35 degree of angulation. The movement when the shoulder is being abducted. And another thing, in forward flexion also, it will have a 30 to 40 degree of movement, translatory movement happening there. And also it works, it moves whenever you do a circumduction movement and all that, it will move. Remember about the joints in this area. We have the glenohumeral joint here. Then we have the sternoclavicular joint between the sternum and the clavicle, where the acromion process and the clavicular lateral end will have a joint together. It's a diarthrodial joint. Remember that ones. That means synovial fluid is there. Synovial membrane is also there. Then we have the acromioclavicular joint, and we have the scapulothoracic joint. It is not a joint, but it's a translatory movement of scapula on the ribs in the behind the part. Because many of the movement, especially when abduction is done and all that, till about 130 degree, 140 degree of abduction, it is done by the deltoid, and after that, at the glenohumeral joint, the movement happens. After that, whatever movement is happening is at the scapulothoracic. Remember that is an important area. Many a times muscles like serratus anterior, the trapezius and all that, if injury is there, the patient will come with the shoulder. I am not able to raise my hand above this level. Injury is because of that back muscles, but reflect on shoulder movement. Okay. As we move on, we need to know the rotator cuff muscles. As you know, everyone might be knowing the sits muscle. I am not explaining that too much, but remember where it comes. Now, first one, we have the supraspinatus. Supraspinatus from the above the spine of the scapula, and it comes and attaches to the greater tubercle. Now, then second one is infraspinatus. The same way from the infraspinous fossa of the scapula, it will come and attaches to the greater tubercle. Then there are two muscles which usually we won't be able to see. See, this is from the supraspinous and infraspinous area. Next one is the subscapularis. The subscapularis is that is the muscle that helps in medial rotation. This is the movement, medial rotation. I will explain the movements in another slide. In medial rotation, the subscapularis is a very small muscle, very large muscle that actually comes from the ventral aspect of scapula and comes and attaches to the lateral, the lesser tubercle. Now, the last one is teres minor. The teres minor is from the lateral border of scapula. Again, it comes and attaches to the greater. Now, these muscles all go through this confined area between the coracoacromial. Many of them passes through between the coracoacromial ligaments and all. So what happens? The ligaments will be above, the tendons will go below. As the joint is being pushed up, you can have. Now, to view the coracoid process, it's easy actually. Examination you can do. Just push the shoulder back, and you can see Arvind's coracoid pushing up. See, this is this one, and as it is pushed backwards, you can see the coracoid process. This is the coracoid process. This is the acromioclavicular joint. It's easy. If you do this, then you know from where to where the pain is. If patient comes with a teres minor and the pains and all that, it's usually on the posterior aspect. They will come that I am having pain in back of it. Whenever it is subscapularis, it will be usually in front. They will complain of the pain. That you need to remember. That again we will show and explain when the hands-on training is going on. Okay. Now, for supraspinatus, the test usually we give is the abduction test. You know abduction. Abduction is the movement. Right now, what Arvind is showing. Is the video visible? Ashwin?
Yes, sir.
Yes, is the video visible? Yes.
Yes, sir.
Yeah, now this is the abduction, and up to 180 degree, we can do the abduction part. Now, when you do an abduction is controlled by...
Hello? Hello, am I audible?
Yes, ma'am.
So do you want to have a closer view on the video, or is it fine? Are you able to view?
If it is closer, it will be better, ma'am.
So yeah, yes. Or any of you can just unmute your mic and give your suggestions if you feel difficult in understanding.
Anyway, we will in detail, we can explain.
Yeah, anyway, all these things we will be explaining in detail in the hands-on training. So this is just consider this just as an introduction so that we can cut short the length of theory class there. But still in between, if any of you have any suggestion, feel free to unmute and tell us.
Now, okay, we continue. So abduction, this is abduction, shoulder abduction. And shoulder abduction, 3 stages are there right now to remember as a clinical point of view. 0 to 15 degree of abduction started by supraspinatus muscle. Once it reaches 15 degree, deltoid muscle takes up, the middle fibers of the deltoid. Deltoid plays an important role in the shoulder part. Now, as from 15 degree, it will take up and it will go up to almost 150 degree, it will go. Once 150 degree it reaches, then the rest of the movement will be taken up by our posterior muscles, especially our trapezius and our latissimus dorsi. All these takes up, and the scapula will twist or roll on the posterior part of the on the rib cage part. Okay. Now that translation movement actually helps us to have a 180 degree movement. Now the thing is, you need to remember, in some textbooks, you can see that the range of movement in abduction is written as 140 degree, in some textbooks 150 degree. Some will be saying 180. Now that is because of difference of opinion between the authors, because glenohumeral joints movement is only up to 150 degree. The rest of the movement happens at the scapulothoracic. So that's the difference that you need to understand. But it's not an error. Then the next one is with the rotator cuff is infraspinatus and teres minor. Now, infraspinatus and teres minor usually will have a posterior axillary pain. Somewhere in this area, patient will come with the pain part. Now, next one is for the subscapularis. To assess the subscapularis, usually we do is an internal. Right now, what Arvind is doing, it's internal rotation of the shoulder. As you can see, the shoulder head I will be demonstrating with my hand. As the shoulder goes in, you are internally rotating the humeral head. Now, as it goes to the back, if a patient can do, we will learn about this Gerber's lift test and all that we will come later. At that point, I will explain. It's easy internal rotation. If can be done, no problem with the subscapularis tendon. Okay. Moving on, we have key stabilizing ligaments in this one. Multiple of them, which you will know by the name itself. We will know, especially the coracoclavicular ligament, which has two divisions. One is the conoid one, and another one is the trapezoid one. Then the coracoacromial, the glenohumeral. So multiple ligaments are there, which you might have learned also in your anatomy classes. Now, these ligaments are important. In a way, you can explain the glenohumeral ligament. Glenohumeral ligament has three parts, because showing those ligaments is difficult, because it is very, even when you are reading your anatomy textbooks, many a times it is confusing also. Glenohumeral ligament, when it comes, it has three parts. It's a superior part, there is a middle part, and there is an inferior part. Just to remember, inferior part of this ligament is the major one that actually prevents the anterior and inferior dislocation of the humeral head. It will be finely attached with the upper. The superior one actually prevents the superior translation, because it won't prevent. If you fall on the hand, it will prevent that part. Now, shoulder stability factors, multiple these things are playing, especially all the muscles, whatever we explained, our rotator cuff, our deltoid, our biceps, all plays a role in maintaining the stability of the shoulder part. Now, any of this weakness is there, the patient will come and show symptom. If it's a traumatic injury, remember, very important part. If it's a traumatic injury, patient will come with growth swelling. Whatever test right now we are going to show will all come positive, and you can't make a clear-cut diagnosis at that point. So remember, any traumatic injury, this thing is not going to work. You need to go for any advanced investigative mechanisms to find it. Okay. Yes. Can we move on?
Yes, sir.
Am I too fast, or should I slow down?
Okay, sir. It's okay.
It's okay. Anyone feeling any difference of opinion? Please come up. Okay. Yes. Okay. Now we will start with the range of movements of shoulder. The first one, you can say, is flexion. We call it the forward flexion. You can take it up with the fingers pointing upwards. You can take up to 180 degree. That is a forward flexion that you can have. Forward flexion. After that, abduction, as you know, I have explained it earlier. This is abduction on the lateral way when we move. This one, when you do, is the adduction. Many a times adduction, it is said to be 0. In many textbooks, you can see adduction as 0. But if you are able to cross over to the next shoulder, usually you are adducting the shoulder mat. But ankle is not there. Ankle is still 0. There is no movement, but this is the adduction what we'll do. Now, 2 more points are there. One is internal rotation. The way when you bring your hand to the back, we have the internal rotation happening. And another one is external rotation, elbow flexed at 90 degree. Then we have a lateral movement of the arm happening. At that point also, lower arm moves away. You can have a external rotation happening. And that is about 90 degree. Again, it will come. Now, this angle is, all these are important. You can see as people age, the muscles become weaker. There will be difficulty in moving the in the normal range also. Even people who are in their 50s, they will come with problem. They will come with issues stating that I am not able to raise my arm above the shoulder. Many times, the main reason is sarcopenia. Muscle grip, muscle strength goes down. But as soon as you reach 40 years of age, if you are not doing proper muscle workouts and having proper protein intakes, definitely there will be gross sarcopenia happening. And that you won't recognize also. Many times you will go on omitting those things, and finally yes, they will come when you are having difficulty in doing many of these shoulder movements. Now, flexion part and the movement part, again, we will do the explanation once we come for the hands-on training. Now, we will go into the common pathologies of shoulder joint. Common pathologies, first one we are going to explain is adhesive capsulitis, also known as frozen shoulder. A frozen shoulder is a condition usually we will get in our clinical this thing. And Ayurveda doctors are considered to be a very good in practice of this frozen shoulder. One of the main reasons is it has 3 phases. The first one is a pain phase, second one is a stiffness phase, and the third one is the thawing phase. Now, many a times what happens is patients will be going for an allopathic consultation initially. When the pain is there, they will manage the pain. The condition won't resolve. Then again, they will come to, they will have the stiffness phase. That time they will, usually by the mid of the stiffness phase, they will lose hope of modern medicine and they will come for Ayurveda treatment. Now, once they come for Ayurveda treatment, usually what happens is we will be doing our Svedana karmas, all those things at that point. And what happens usually at the thawing phase, automatically the patient feels that yes, everything is getting corrected. And they will give credit, but you should know, as a clinician, you should know it has 3 stages. The importance is assessing in which stage the patient is and informing the patient upfront. Because what happens with many modern practitioners, because they don't have time, they won't spend time also. Recent statistical studies shows doctors usually spend less than 3 minutes with a patient, single patient, and that is very few time, and they won't be explaining much of the things. Now, as Ayurveda doctors, if you can explain this, assess the patient. Patient is coming with pain. Yes, pain is there. Then you can say that minimum, it varies from patient to patient. Minimum, it will take 4 months, sometimes maximum up to 8 months, pain phase. Second one, as it goes, the stiffness phase, the same way the phase can be. And another one is the thawing phase. The thawing phase will happen at the end part when the joint becomes again free. The capsule becomes adhesive capsulitis. The capsule becomes free. Multiple pathologies, comorbid conditions the patient will have, usually diabetic, liver-related problems. All these things can add to this frozen shoulder thing. The major thing, the pathognomic sign, you know what is a pathognomic sign? Hope everyone knows it, but again, I will tell you, pathognomic sign is like if that sign is there, if the doctor sees that sign in the patient, then definitely then and there, the diagnosis can be done. The basic and the most important thing you need to do if to diagnose a frozen shoulder is to do a external rotation. If the patient can't do external rotation, mark it, it's frozen shoulder. or rotator cuff one tier is also there. That we will come when the rotator comes. I will explain. So remember right now, external rotation, if it is possible, if not possible, then and there we can. Then additional 2 more tests we can do in this one, that is called the Apley's test. Apley's scratch test actually. Multiple Apley's are there. The Apley's scratch test. There are 3 versions of Apley's scratch. First one is Apley's shoulder scratch. Shoulder scratch, you will opposite shoulder. If you can touch, that's Apley's 1. Next one is shoulder abducted, externally rotated, and scratching at the back. You can turn. You can see this is if the patient is able to do this one. That is Apley's 2, second scratch. And the third one is if the patient is able to do behind, how high up they can come. Usually up to T4 level, they can bring the finger up. So if that is possible, this is easier. Now, in my clinical experience, what I usually used to ask the patient is to do a both hand this thing. If the patient is able to touch like this, because anyway, both shoulders we have to examine. If the patient can do this, yes, done. Then ask the opposite way. Opposite way, if it does, the both shoulders are tested for both sides. They have to touch. If they are able to touch, that means there is no capsular adhesion, no adhesive capsulitis or frozen shoulder is there. Yes, done. And remember one thing, if you advise for an X-ray, X-ray will be completely normal. Nothing will be there. No way you can this thing. These tests, scratch test and external rotation is the 2 clinical ones. You can have an idea of the frozen shoulder. Okay, because otherwise doing MRI and all that, yes, you can. The capsulitic adhesion can be found out, but again, it's very costly. Clinical diagnosis is way better in doing in such things. Now, the major treatment protocol with adhesive capsulitis, whenever a patient comes to me, this is the protocol I usually follow. First will be Rukshana. I will give Rukshana. You can give none of the oils will be used. Remember, don't allow the patient to touch oil or put oil on their body. Usually, Rukshana will be Valuka or Churnapinda. That will be continued for 5 to 7 days. I will continue. Remember, if the patient is of Pitta Prakriti or some too much of Vata predominant person, and in such cases, mild application of oil just before the procedure can be done. Okay, once with the 7 days itself, the patient will say that, yes, my joint is little loose. I am able to move it. Then we will shift to Patrapinda Sweta. Along with, I will administer Pratimarsanasya, oils which you can opt for. I'm not saying the medicines because medicines depending on the patient we will be giving. But this is the protocol I follow. Once it reaches by 14th day, I will ask the patient to have active movement of the shoulder. Active movement of the shoulder means, yes, even if he is having difficulty with the pain, bear the pain. I had a patient, he was 68 years of age, actively playing tennis. Now, the person had frozen shoulder. Came with this, I have difficulty. I'm not able to, because to play tennis, you need to throw the ball up. On the left shoulder, he was having. Right was okay. Now, he was not able to throw. Then what I advised was, don't do a short throw, keeping because this also you can help in movement. This by flexing, not using the full length of the shoulder flexion. Don't do that. Just have the elbow flexed and just to do the throw part. Now, this also worked. Now, he was regularly playing during the pain phase also. Done the treatment, inflammation was brought down, pain came down, and he was able to play. And physiotherapeutic movements. Physiotherapeutic exercise work wonderfully well in this condition. With simple things like a water bottle, a 1 liter of water bottle, bottle is enough to do all sort of procedures. Usually we will start with a pendulum procedure where the hand will be like a pendulum. Hope it's visible. pendulum procedure, usually you will have, first is free movement. You can have the pendulum movement any way, like a pendulum. You can do multiple movements, make the shoulder relaxed and loose. That's very important. And once the pendulum exercise patient is able to do, then with the weight, we will start 1 liter bottle, 2 liter bottle, 3 liter bottle you can. Or people who are having elastic bands or anything, that also is very much helpful. We don't need anything else. These exercises are enough to keep the patient in from getting the shoulder more and more adhesive. As you move more, the joint, the capsule becomes loose and loose. Okay. Remember, one major thing you need to differentiate at this is sometimes in Parkinson's patients, the same thing will be coming up in initial phases when the Parkinson's is not diagnosed. Now that is something of tricky. That is clinically you need to assess that patient and do multiple tests for Parkinson's and rule out whether it's not Parkinson or it's just the frozen shoulder. Okay, please take care of that in mind. Now, next one is the painful arc syndrome. Painful arc, everyone knows that in the arc of movement, there will be, this is 180 degree of arc of movement. We will have pain maybe from 60 to 120 degree. This is the painful arc. Many a times if the patient is having an impingement is nothing like whenever between a confined space, if the tendon gets impinged or the tendon sheath gets impinged, that's enough. Once that impingement happens, it will have an inflammatory process that will be going on, that will again reduce the space in that area that can cause. Then also painful arc, this thing will be, we call it as a painful arc syndrome. Now, usually causes of painful arc, you can say by these ones, we can have either a supraspinatus tendinitis, you can have a supraspinatus tendon tear, or you can have a calcified supraspinatus subacromial bursas. All these can result in, or even greater, the major one is, because that definitely the patient will be knowing, the greater tuberosity fracture. If in such cases also, greater tuberosity fracture is nothing. Your patient will come with a clear-cut history of trauma, fall on tip of shoulder, slip and fall, whatever. There will be a clear-cut this thing. You are not going to miss that one. But rest of the things, there is high chance, because it will be a slow progress, especially the supraspinatus tendon tear. It will be a very slow process. Initially, it will be a mild pain, mild ache. Patient will be saying, I am not able to sometimes to comb hair. People who are bathing, I am not able to wash my hair with that limb. To put a shirt on, like those things, they will notice. They won't recognize it as this supraspinatus tendon tear. Now, it's up to you to, as when the patient comes with a pain, to rule out whether it is supraspinatus tendon tear or not. That's very important. Remember, if it's a full thickness tear, then surgery is the only option. Ayurveda can't do nothing in full thickness tears. But if it is mild one, grade 2, grade 3, yes, we can do wonders with the patient. We can decongest the entire joint because our procedures have that wonder effect. And recently, one more patient, I will tell you, with the thing is ACL tear. Patient had about 70% of ACL tear. It's not related to the shoulder, but again, the case is wonderful. That's why I am sharing. Initial MRI is clearly advised. ACL tear was there, meniscal tear was there. Patient was advised to do surgery, but patient was initially hesitant, came to me with this treatment part. I said, meniscal, I am not sure of, because meniscal injuries are notorious. It's not at all possible. But ACL, I was confident. ACL, I said, don't worry. Even if it is 60, 70%, grade 3 tears, not a problem. We can clear it. I asked him to give me 4 weeks of time. Yes, after 4 weeks, yes, we did the treatment, whatever it is. Maybe on the day we will discuss, someone remind me, we will discuss the case also. After 4 days, what happened? 4 weeks, what happened? I advised the patient to go for. The pain was, the swellings, everything came down. But whenever the twisting movements or the shearing movements of the knee is happening, patient had pain. Meniscal is not healed. That I clearly told. They went for a MRI. Second MRI showed a mild tear in ACL. There was, so it is almost healed up only. Now, meniscal was not at all. So again, the option was to go for a surgery only. He was posted for surgery in KMC. I think on March 4th, he underwent the surgery part. Only for the meniscal, arthroscopic surgery was done. And before surgery, the surgeon who was doing, orthopedic surgeon who was doing, clearly said, yes, we will be doing ACL also because you had a almost near to full thickness tear of ACL. So definitely you have to go for that one. Because they were speaking with the MRI report initially they had, which was done in KMC only. The second report they didn't see also. Now, what happened with this patient under the surgery table? What happened was they found that ACL was almost intact. ACL didn't had a problem. They clearly said ACL is almost intact. No issues, no surgery required. Now that's a wonder of Ayurveda. Remember, if you do it properly, if you have the diagnosis properly and treat it properly, we can cure these conditions. I'm saying not everything, but 80% of the cases, we will be able to handle it beautifully and without surgical scars. Now, he has done surgery. He is now in crutches. Again, inflammation, everything started because it will obviously, after a surgery, it will be there, and he is under rehabilitation. Okay, we will be moving on. Diagnosis of painful arc is what we call is an empty can test or a job test. Usually the shoulder will be abducted. Now, an empty can or a thumbs down test or a job test, it is called as. You have to do is, yes, you can see the movement happening. Hope it is visible to everyone. Yes, this is an empty can test. Like you have a can in your hand, you want to empty. Now this movement, yes, if you are not, this is supraspinatus tendinitis. You can rule out supraspinatus tendinitis with this one. Second one is drop arm test. That is also supraspinatus tendon here. Drop arm test, also known as the Cotman's test. Now you can see, hold the arm. We will hold the patient's arm up to this level, 180 degree of abduction, and ask the patient to bring it down very slowly, in a very slowly and a controlled manner. Now, for Aravind, it will be easy because he will be bringing it down easily. This is also will help us determine the supraspinatus tendon here. If the patient is having a supraspinatus tendon here, as soon as it comes down to an extent, once the scapulothoracic area is given, then he will have a fall. He won't be able to do it in a rhythmic way because pain will start. Because the joint space is reduced. As the joint space becomes again reduced, and holding the weight of the arm comes, the muscle will give away. Now, the next one is Hawkins test, Hawkins or Kennedy's test. That is for the impingement, again for the impingement part, or subacromial impingement syndrome. Usually we can find it. You will be forward flexion of the shoulder will be done to 45 degree, elbow will be flexed to 90 degree, and we'll ask the patient to have a movement away from the body, and we will resist. So that will be giving an idea if the patient is having severe pain. Definitely that subacromial impingement we will be able to see. Remember, we will do hands-on training on the next day, but I want you guys to read and come, or if it will be better, we will have more discussions and all that. Now, X-ray usually is done when there is a greater tuberosity fracture or done. Okay.
Sir,
Yes.
sir, can you demonstrate once more, sir? That last one.
Which one? Hawkins test? Kennedy test?
Okay, yes. Yes.
Kennedy test, from neutral position. We will bring the shoulder into forward flexion, about 45 degree. We'll have the elbow at 90 degree. By this point itself, the patient will be having experiencing pain. If there is any supraspinatus tendon tear or anything, patient will be saying, yes, I am having pain, I am having pain. Usually what we will do, we will have a resistance. You can feel the muscle getting toned, correct now? Yes? If this is Hawkins or Kennedy test, Kennedy's impingement test. Hope it is clear now?
Yes, sir.
Yeah, okay. Now, Acromioclavicular joint arthritis. That's another common thing that with elderly people usually come. Acromioclavicular joint is more prone for arthritis or OA shoulder than glenohumeral joint. Glenohumeral joint arthritis also will be there, but mostly it is acromioclavicular joint that comes. So remember, it's a diarthrodial joint confirmed with the help of cross-body abduction. Cross-body adduction. Cross-body adduction is this one. If the patient is able to do, OA patients usually will be having difficulty in doing this movement. And even for shoulder dislocation also we will use, if you can touch the opposite shoulder, that's one common test we use. If you can do this, yes, shoulder is in its normal position. What we are looking for is the patient will say that, sir, while that movement is doing, that cross-body adduction is done, the patient will say that, yes, I am having severe pain in my, because there will be osteophytic changes. It can be on the glenoid, it can be on the acromioclavicular, those osteophytic changes and sclerotic changes of the articular capsule will be there. Now, in such cases, the patient will have pain. They will say that, yes, it is difficult. And remember, osteoarthritis is something which can happen to any one of us. It is age-related. It is a degenerative condition that happens to us. Joint, so the joint line, the joint labrum, everything will be damaged with the osteophytic changes that happens. X-rays is the major one. One clear-cut X-ray is enough. Epilateral view, AP view is enough. You will see that multiple osteophytic changes in areas. You can see sclerotic changes in some joint line reduction, joint space reduction. All those things you can see if you take an X-ray. Now, any of these tendon tears, if you diagnose with a patient with a tendon tear, obviously we will be doing the banda, which we will do. The pain relief is your first aid. Patient's main concern will be the pain part. Rest they will be okay because they need to do their day-to-day activities. Now, before doing, except in adhesive capsulitis, before doing any other procedure, first thing you have to do is bring the pain down. That is one main thing which I usually do. And for that, we will be using banda. Banda will help in stabilizing the joint. It will reduce the movement in that area. It will give sufficient amount of oil, which is Vata Pitta Samana. Usually, we will be using Muruvanna, or if the condition is pure Vatika, we will go for Bala Taila or Dhanandran Taila. Or if you have, if the patient is well off, then we can have Mahadharana Taila also, which we rarely use right now because I am a person who wants to sustain the Ayurveda practice on a longer way. Mahadharana Taila is not a drug that is a drug of choice for me on that aspect. Now, even Dhanantara is also very costly if you are making it in a proper way, but still that is one drug which I regularly use. Now, the pain is reduced. Once the pain is reduced, then rest of the Panchakarma procedures we will start. Till that point, we won't be, especially in tear, any rotator cuff tear or impingement things. That's the first thing we will go. Remember, banda first. Now, in OA patient, amatwa has to be avoided. If the patient has sthanika amatwa in the sandhi, then definitely don't go for banda first. Do some rukshana, bring down the amatwa. Once amatwa is over, you can do to reduce the pain. Still pain is there, patient says of pain, use banda. Once banda is done, the pain will come down. Once the pain comes down, that directly it's proportionate to the inflammatory markers in that area coming down. That's my way of understanding. And this is my line of treatment, which is taught to be my gurus in Trivandrum College. Now what it is, once the pain comes down, I will start with the rest of the Swedana and Snehana procedures, which based on the patient we will choose. Either a Patrapinda Sweda or we will go with the Churnapinda Sweda. If more Rukshana is required, we will go. And then we will go to Sthanika Dhara and end with a Shastika Pinda Sweda. Many a times, even in shoulder dislocation, partial dislocation, recurrent dislocation cases, if you do it in a repetitive way, not in one sitting, definitely, especially if the patient is of having recurrent shoulder dislocation, this condition won't get cured with a single sitting. You need to do every 6 months, one set of this procedure. Do it, so rehabilitation of the shoulder has to happen. Modern also suggests the same thing in recurrent dislocation. If you are not going for the surgery aspect, then definitely this rehabilitation part you need to do regular aspects. With the tendon tear, usually if the treatment is for 3 weeks, the patient is undergoing treatment for 3 weeks, double the time. So 6 weeks will be the rehabilitation time. Remember, rehabilitation has to be done in any of the orthopedic injuries. You have to go for rehabilitation. Without rehabilitation, proper recovery won't be there. For the time being, the patient will come out of the pain, his symptoms, everything will come down, patient will be happy. But if you don't advise them to go for a proper rehabilitation techniques and all, definitely they will be coming back with this injury. And now with with physiotherapy clinics and hospitals coming up, many of them are regularly going for this physiotherapy, because I know many of the sports persons also, they regularly use this as to recover back from an injury and all. Now that's important thing you need to remember. Okay. Now we will come to the final part of this one, where we will be discussing about the marmas. Now the wonder part, because marma, how we learn? We learn that yes, saptotram marmasadam, like that we learned. And we learned that in upper limb we have 11. We learned in uras we have, in prishta we have, in lower limb we learned jatrurthva we learned. So like that we learned. We never learned it with a single point. If a patient comes with a shoulder joint pain, what are the marmas to do? Which marmas we can use? And using of marmas is something which you can teach the patient also, because they can do at home itself. Now, basically, I understood after reading anatomy and comparing it with this Varmam technology, techniques of Tirumular Varmology Institute. What I have found was most of the areas, or most of this Varmam areas, are actually pulse points. I found it in multiple, or else it will be ligamentous areas, strong ligamentous areas that will be either pulse point or ligamentous areas. And many of them, when we explain the Varmas in this area, we will be able to tell you, I will be able to tell you that one. The major Varma that explained in Varmology Institute was for the shoulder, any injury to the shoulder part is Chavu Marma. Now this is Tamil Siddha system, remember. So it will be difficult for you to assimilate. It is called as Chavu Marma. I think you can do, or you can trial on your body itself. We have the deltoid muscle. The Marma, as per text, it comes like from the shoulder tip 4 angula below on the anterior aspect of the shoulder. Now you can see we have the deltoid coming. We have the biceps. You can flex the muscle. You can see the biceps. Yes, we have a groove in that area coming up anteriorly. Now relax. Now as the groove comes up, you can see my finger going. We will be doing in detail on Sunday. We will be doing this. In the groove, you can actually feel the pulse. If you try on your own, you can get the pulse. If you multiple points you touch, you will get the pulse. Once you get the pulse, that pulse is actually our brachial artery that comes down. Okay, that area is usually pressed with the middle part of your interphalangeal joint of your thumb. What you will be pressing it 3 times and releasing it. 1, 2, 3. Usually it is done like. Along with that, their technique is they have a varmam in between our, we call it our kshipra, angushta anguli madhyastham kshipram. Some we can directly compare, others it's not possible. It's called as kaulik kalam. In their technique it is called as kaulik kalam. Here also we have a pulse. We will have, as soon as the scaphoid, above the scaphoid, our radial artery comes and goes down beneath, and this area also we can get a pulse. And that area with the pulp part of our 3 fingers, middle 3 fingers, we will be pressing that area towards the thumb. Remember, that's important, towards the thumb, not towards the finger. not like this. It has to be towards the holding the thumb, towards the thumb you need to do, along with this one. Along with the Chavu Marma, you will be doing 1, 2, 1, 2, 1, 2, 1, 2, 3 times. Usually this is the way, and it increases the blood supply to the arm. It gives energy to the shoulder also. Now, if usually that's the thing, and my concept of this one is, as the arterial supply increases, usually the inflammatory markers, the mast cells, all those things will be taken off by this increased influx of blood flow. That can be done with the help of this Marma techniques. So 2 Marmas over. Now, the next Varma is Kadirkama Varma. Kadirkama Varma, you to know that we all know our jugular knots. Now, here pulse, you can't get it, but I will tell you the details with the anatomical reference. We have the suprasternal notch or the jugular notch, 4 finger below from the notch. 4 finger below from the notch, using your hypothenar eminence, 4 finger below, using your hypothenar on the sternum, we'll be doing 1 press and release. Press, release. Now, this area, hope you remember the plane of Ludwig's plane that separates superior mediastinum from inferior mediastinum. Now, that exact area is where our arch of aorta comes. And arch of aorta, remember the bifurcation, the brachiocephalic and the subclavian and all those comes up. So what happens, that is the area where the blood supply to the arm is starting. And that is the reason why this area gives energy to ancient Acharyas. They didn't know this part. What they said, they thought that this pressing this area will give energy to the hand. So this one is Kadirkama Varma. Next 2 Varmas are in our above the clavicle. Supraclavicular fossa. We know, if you can bring it down. Yes, yes, we have the supraclavicular fossa. The muscle which I am touching right now is trapezius muscle. This is trapezius muscle. Now, with the 3 fingers, pulp of 3 fingers, put in that fossa. If you put in, you can see, if you touch your supraclavicular fossa itself, you know that you can get the pulse. That's a subclavian pulse, actually, you will be feeling over there. Now, press, release 3 times. Press, release, holding the trapezius, squeezing it together. Press, release 3 times. Okay. That is, this Varma is known as Kakateka. Okay, Kakateka. Now, next one we will be going is Vilangu Marma. Vilangu Marma is somewhat in front of clavicle. We have a depression here near the coracoid. Another one. Again, what we will be doing, the mid part of these 3 fingers, we will do 1 rotation laterally, then rotation 3 times medially. Again, the same thing, the blood supply will be more and more, it will be improving the blood supply to the arm. That's a concept. Here, we won't get any arterial pulse or anything, but the plexuses, all those comes, the axillary area, everything what comes has a transverse through this one. Maybe it increases that one. But here we will get the brachial pulse. Here we can get the, between the, in Chavu Varma area, we will get the pulse. The same route we can see from the Ludwig's plane. We did the pressing part 4 angula below the suprasternal notch or the jugular notch. From there it comes, again the subclavian will be stimulated here. Below, as it comes, here we will be mostly the axillary will be stimulated. As it comes down, the brachial will be stimulated and the radial again stimulated at the end. Now, the next 2 Varmas are Pirathare Kalam. It's in Tamil, that's why even my pronunciation might be wrong. Pardon me. Pirathare Kalam and Yendi Kalam. Now, these 2, Pirathare Varma and Yendi Kalam, these 2 are actually the ligamentous Varmas in this area. Ligamentous Varmas. Pirathare Kalam is at the posterior aspect. posterior axillary fold actually. In that area, if you can hold from this side also, you can see that you can feel a ligamentous area that we will do on that day. On that day, I will show you the Biradre column and the Endi column. Endi column is in the anterior fold. The same way in the anterior fold, if we palpate, we can get the Endi column. Okay, Piratare Varmam and Endi column. That ligament, if it is torn, again the muscle will be, again the entire arm will be will go into paralysis. This, remember, these Marmam techniques were used for both defense part, offense part, and as treatment aspect also. Because our science was developed, because I am a Sausruti, so whatever I speak is regarding that aspect. Whenever an injury happens, the treatment is to be done in a faster way. So this Burma technology is very good in doing those things. This once hands-on training happens, you will understand it in a better way. I think Aravind is knowing right now, which I am holding. This is the ligament. If that ligament is cut, I don't know which ligament, because that requires require advanced studies. Maybe doing an MRI and finding it and triggering that point. We have to see that, but right now it's not possible. So just anatomically, I can show you where and how to manipulate it. Okay, that we will do. And finally, and with this, we come to the end of our online session. I want you to come up with doubts on Sunday, so we can make it an effective part. Conducting this online session was because in offline, when they come, explaining this much of time, I think almost 1 hour we have done. This 1 hour we can save over there, because we are hiring this is right now I am doing from my home only. But the outside, when we come, more time can be given for hands-on training, which we want all our young budding doctors to trained in these things, so that in future they will be confident and go out and do procedures. On the day we will be doing Banda. Banda will be done, demonstrated first over there, and individually you all will be doing, and the Marma points also you will be doing over there. And the tests, whatever we have done on that day, we will be able to demonstrate it individually, one-on-one if you require, otherwise not. Because you can have a number of YouTube videos to explain multiple. And remember, these are not the only tests. You can have multiple tests. We can have the knee test. Multiple tests are there for the shoulder part. The subscapularis, the lift test, because that is something which that comes, because that is because already I have shown internal rotation. This is the subscapularis muscle. Once the lift off happens, yes, this is when the subscapularis muscle is most toned. To get to the exact idea, you can get, if the lift off is possible, yes, it is done. Now, what I will do, I will ask the patient to resist that I am pushing towards you, you should resist. Yes, if he can resist, means subscapularis tendon is perfectly all right. Like this, we can make a clinical diagnosis, and this clinical, again, I am saying clinical diagnosis is an art. Art we try to perfect, but in lifetime we won't, because each day we will be learning new tests, and we will be increasing our clinical vocabulary to our maximum level. Okay, bye guys, seeing off now. Any questions if it is there? Yeah, please share us a note or something, or maybe on Sunday we can clear it during the offline session.